There are about 7 million people living in rural and remote locations around Australia. That's about 30% of the entire population. And it's well known that access to quality care is poorer, and health outcomes for people in rural and remote locations in Australia is consistently poorer compared to other parts of the country. There's a really strong need for us to create an innovative and sustainable healthcare system for rural and remote Australia. And technology can play a huge role in that. I'm here in Perth for the 17th National Rural Health Conference, and here with me are hundreds of clinicians, researchers and policymakers who are seeking out information and inspiration on rural and remote health and wellbeing. All this week I'm attending sessions on community engagement and co-design, health promotion and prevention, mental health, First Nations chronic conditions and so much more to unpack the big issues facing communities and providers in rural, regional and remote parts of Australia. We collaborated with HealthBeats here on the expo floor to set up a studio space to interview some key voices on these topics, and we're bringing you some of these conversations in this episode today. Collaboration starts with a conversation, Team HealthTech. Let's make it happen.
My name is Melanie Molluso. I work at Echuca Regional Health, which is a small rural hospital in Victoria. My background is critical care nursing, worked mostly in emergency departments and ICU for many years. And then we found that, felt like I wasn't really getting anywhere. So then I've moved into the community space and supporting people that way, which I found is much more rewarding and having much better change with people.
Excellent. And so we're here and we're exploring, perhaps celebrating, but also kind of diving into rural, regional and remote healthcare. And sounds like, you've been in the thick of that. Tell me a little bit more about those. You mentioned, the need for some change and a project. Take me through that journey a little bit more about what that was about.
Yeah, so I've been working with project work within our hospital. And the first project we were working on was preventable hospitalisations. So there's certain conditions that are deemed avoidable. If people are managing their health well, they can avoid a hospital presentation or admission. So working in that space was fine. There was a lot of patient education, a lot of healthcare education, but we found that we're still missing that piece, which is where remote monitoring came in. So we found once we added that missing piece of monitoring a patient's vital signs out in the community, and we were able to support people around those vital signs, management, what to do with the data, we found that was amazing. That really helps support people at home to stay well and stay at home and to manage their health conditions. It really gave them a vital piece of information.
That's interesting. And to really kind of understand that problem in the first place, if not for that kind of solution, walk me through what that looks like, be it from is most of the pain seen on the patient side, the carer, the clinician, or all of the above?
Yeah, all of the above. So on that patient side, for them to be able to have real data that applies to them, they can see how that data relates to how they're feeling, what their health conditions like, how they're tracking. It really gave them that feedback of their health, having that data that relates specifically to them, accessible, that they can share with a healthcare team and with their family members as well. It really gave them their feedback and how to look after their health. And when the healthcare providers come in, is to be able to monitor their patient, not just doing a once-off, blood pressure, oxygen level. This is over days, weeks, months. We can see how that patient is tracking. And then we can give them tools to use so that they're getting this data at home. So what do they do with that? They might have this blood pressure that's really high. Well, what do they do? That's that next step, and how to get the education then with the healthcare providers, how to educate their patients and support their patients to do something with that data.
I think we miss that part sometimes, or that's perhaps a little bit harder to quantify, because conceptually that makes a lot of sense. Well, with better access to data, then everyone kind of knows what's going on. But, from a patient side of things, it's kind of like, well, what do I do with this? Now, that's great to know, but now what? So I think that's really important. And I think about it from, you in the project role, it'd be good to understand, the motivation behind that. I can understand why there would be benefit, but all these things need to be justified, and you need to determine the return on investment, and you need to prioritize it within the group. So walk me through how that kind of eventuated.
Yeah, so it's all very well to improve a patient's quality of life by coming into hospital less, and we know with a lot of chronic conditions that once they're coming into hospital quite frequently, their risk of death increases. So, yes, they're really important things, but to really get that healthcare buy-in is reducing costs. So if we can reduce hospital admissions, the average hospital admission is, $3,500 for a short hospital admission. So we can prevent some of that. The dollars are there. That almost wasn't enough. So then what we did is it's what started off as a project. We linked in with an existing funding program. So we linked that remote monitoring in a pre-existing funding program that we had. Now it's just business as normal. So we use these remote devices as part of our core business. We didn't have to attract any extra funding. We didn't have to lobby anybody. We just use it as a pre-existing program.
I think in the current climate of scarce fund, it feels like there's less and less funding available, although there's also more and more need for innovation. So there's this constant tension between investment and doing things in an innovative way. And there's certainly opportunities for technology to provide services at greater scale and have that impact that we talk about. But I think that's a great example of, looking at the available funding and the way we do things. Are there ways to perhaps redirect how we do some of these things so it falls under that bucket? And there's probably a lot of lessons there for the broader health system to kind of perhaps put a new lens on some of these challenges, because that can be the trickiest part, is all of it makes sense, but there's no funding.
Absolutely. You can show it in as much as you like, and everyone might agree with you, but to actually show how we can fund this stuff. Yeah. Absolutely. And so what we did, we just looked at what programs we had within our organisation and how we could link these devices in. Sort of looking at things always the same way. So we tend to, if we always do what we've always done, we'll always get what we've always got. How about we put in something different to give us something different? So we put our core business is in complex care, or known as a HARP program, so a hospital admission risk program that we have in Victoria, which we're funded for home visits and for telephone consults. So that funding exists, that we're getting funded each time we ring a patient and talk to a patient on the phone. We're funded each time we go and visit them at home. So this fits in perfectly. We can monitor them and follow them up with their phone, and we're getting funding for doing that. And we can visit a client in their home to set them up, to make sure everything's running smoothly. We can do that, and we'll be funded to the department. And also a hospital in the home. People are at home when they're acute. We can monitor them. We don't have to go out and visit them. We don't have to pay a worker, the use of the car to get there to visit them. Yep. We can monitor them in the department. We don't have to. And it also increases our catchment area. So we can look after more patients, whereas previously, like all rural areas, we have gaps in who we can see. So we might only travel for 50 minutes an hour. So then all these people that live outside of that miss out. They really fall in a black hole. And as we know, the more isolated you are, the poorer your health. Yeah. So if we can pick these people up and help support them, it makes a huge difference.
A lot of sense. And the one thing I've learned and experienced is that it's one thing to get the approvals and the funding and the green light to go ahead with the project, and you've got your kind of key advocates for the thing, and there's a lot of energy, but then you've got to involve and engage with everyone in the existing system to get their buy-in as well. And you can have varying levels of excitement about change and different ways of doing things. How did you approach the implementation and execution side, and what was that?
Yeah, and that was a little bit difficult to begin with, just in that when people looked at the idea to begin with, they're like, something else we have to do. Something else. So we share it within our team. So we started off quite slowly. So We started off with just a few patients on board. We spread it out within the team, so it's not just one person looking after all the patients. When we started the project, it was just me looking after all the patients, which was great, but it's a lot of people. Whereas we spread it out amongst our team, they found they always had support, so they always had a support person to come back to help them. Oh, and now it's nothing. That probably took, 3 months of onboarding staff, showing them, getting the buy-in. I think where the real buy-in was that they were able to see the difference it made.
Yeah.
They could really see their results. They had more to work with. They could really help their patients better. So they could see when a patient was deteriorating early on and able to put things in place for that client so they didn't have to present to hospital. I think that got them in. Yeah.
I mean, that makes sense too. Like if you start to see the tangible benefits and then, that motivates you to potentially do more, or at least, continue to work with the solution and suggest improvements, but in a positive, constructive way. So that can be great. So I guess from here, and then, with yourself to a project person as always, on to the next thing or whatever it is, like what's the current focus for you?
So my focus now is more the cardiorespiratory space. So at the moment, I'm working particularly with heart failure clients. So again, it's where remote monitoring is coming into play. We can help monitor these clients at home and see when they're deteriorating and put support in. So they have an action plan that they initiate. So for heart failure, what we're monitoring a lot is their fluid build-up, deteriorating because they're going into fluid overload. So with these devices, we can see that straight away. We can monitor their weight, we monitor their blood pressure, and so that's helping keep them out of hospital. But further from that, I'm doing my master's at the moment to be an NP. So I want to be a nurse practitioner so that I can help support these clients even better.
Yeah.
Particularly in the respiratory space as well, for COPD and heart failure particularly, because these are these conditions that keep representing to our hospitals. They deteriorate so quick and the mortality rate is so high. So what we're hoping to do is to get these people on best therapy is the idea. So using this monitoring data to help get them into better therapy so that prevent them from coming into hospital, because we know once they start representing into hospital, the risk of death increases to like 70% in the next 4 years. So what I'm hoping that we can do is, getting for heart failure, being able to monitor people's blood pressure particularly is really important for medication titration. So where the evidence is to prevent mortality and morbidity, they need to be on this guideline-directed therapy, which a majority are not, particularly rural, because we don't have specialists to be able to see them. They can't come into a heart failure clinic that we have in metro hospitals to be able to be put on this therapy. And the blood pressure is crucial in that, and being able to up-titrate their medications. So really, ultimately, to be able to speak to people, these clients that remotely, no matter where they are, we can monitor their blood pressure and increase their medication to what they tolerate, which will, improve their quality of life, decrease their mortality, decrease their morbidity. We miss that being rural. We can't come into these major centres. For our COPD clients, to be able to get them using their preventers properly, get them using the steroids, get them using antibiotics early on so they don't get those infections that are going to decrease their lung function.
The impact it compounds if you get that up front. You mentioned you mentioned that you're doing your master's and becoming a nurse practitioner, who are kind of like the nurses that got bitten by radioactive spiders. They become superheroes, is the way I understand it, of the health system, because there's there's a limited pool of nurse practitioners within Australia. But for those, I guess it's a double-pronged question. For those like unfamiliar with the role of nurse practitioners and what's the potential there, but also how you see the role of nurse practitioners within the health system, particularly in rural, remote regional areas.
Absolutely. We can fill those gaps where we can't get consultants in. We can really fill those gaps. So we can go remote. We can even work remotely with clients. So I see that as absolutely filling the gap, working with consultants who may be remote.
Yes.
We can be there on the ground, face-to-face with our patients. We can prescribe medication. We can order diagnostic tests. We can then consult with a consultant who might be far away if we're needing more input. we have that ability to really reach the areas where medics cannot.
Yeah.
We just don't have enough doctors to go around or enough consultants, so we can help bridge that gap.
And then so lastly, I'm thinking about, we touched on before that patients, will be able to get, more information and then more importantly, understand what they can do with that thing. But there's always the question about, well, if we give the patients more information and data, there can be overwhelm and sometimes potentially, it doesn't have the impact that we're after. But if we can get the right information to patients at the right time with the right resources, how do you see that, having a benefit that's beyond what we're doing right now?
Oh, absolutely. They need to have a roadmap or a recipe of what to follow. So yes, they might have this health information, but they need a clear recipe of what to follow when they're deteriorating. So we have action plans for diabetes, heart failure, COPD, so they can take action. So they're monitoring their health, and then they've got a clear written format of what they do when they start deteriorating. I think that's been a really key strategy that we've found. We're really wrapping the patient up as a whole, and we're really making sure they know what to do. They don't need to rely on a health service. We're there, we help support them and guide them, but ultimately we want them to do this stuff for themselves.
Yeah.
So we start off giving them all this support, showing them, having a clear plan of what to do. We'll support them to use that plan against their observations to keeping well. But in future, want them to go off and do it on their own.
Yeah.
They get to keep these devices. They can keep monitoring their health at home. They don't always need clinician input. I guess that's where we're headed to, where we're here to have all this support to wrap these remote monitoring devices around their healthcare. But we want them ultimately to go on and do this stuff for themselves, which they can continue to do.
Susi Tegen, Chief Executive of the National Rural Health Alliance.
Excellent. Thanks, Susie. And Aileen?
Hi, my name is Aileen. I'm the CEO of HealthBeats. We are a remote vitals monitoring platform aimed at bringing healthcare outside hospital setting into home.
Excellent. And while I've got you, Aileen, firstly, the HealthBeats, just to set the context a little bit more, what brings you to the conference, firstly?
Actually, we have been a very long time supporter of National Rural Health Alliance. We have been members for a couple of years. Since day one, we are here. One of the reasons why we are here is because of our focus into rural remote health. It actually makes a lot of sense because technology can actually play a big role in bringing healthcare into the remote and rural areas.
And Susie, it's great to be able to have you here. I would imagine a very busy dance card for you over the next couple of days. So to have you here for this conversation is great. Tell me a little bit more about the National Rural Health Alliance and the role it plays within the healthcare ecosystem in Australia.
So we have 53 members, but we also have quite a few allies and friends. We're very much Australia-wide, and we look after the 30% of the population that live in rural, remote and regional Australia, so the 7 million people that live there. We work along the patient journey, so from the day that they're born all the way to the day that they pass away. Also the clinician journey from the day that they decide that they are interested in a health or medical or nursing or dental career, could be paramedics, and all the way to the end of their career journey. And then all the researchers that work in those regions, researching anything from a problem or an idea or an innovation that they would like to commercialise or change into policy. And so we've got a fairly large remit, but we've got some amazing entities and individuals living in those regions. So that is what our remit is. And we're really a conduit between governments, federal, state, but also local government, industry, and those people that deliver healthcare for rural people.
Yeah. And I want to stick with you for a second too, because we'll dive into a little bit more about the role that technology plays within for the 30% of the population living in rural and remote areas. But thinking about perhaps the biggest problems to be solved right now, like broader than technology, and thinking about those clinicians, the patients, the communities that are at most need. What are the conversations on the floor? You know, we're nearing the end of day one of a busy week that's ahead of us. The vibe generally within the event. What are the biggest issues that you're hearing on the stage or out in the conference floor?
Oh, the biggest issues are, well, actually, I'll just say the positive, actually, because people are really inspired by different communities and different individuals that are presenting. It's extraordinary what people produce in rural communities. Because if you said to somebody in the city, you're going to have to raise $800,000 to keep a health service, or you're going to have to travel 200 or 300 kilometres away, in the city, they would go, are you kidding? I've got access to that and I'm not going to drive 200 kilometres. And yet we expect that from rural people. If you were to say you're going to have to try to cobble together a group of people to train our next medical or allied health or nursing population, again, you wouldn't have the same in the city. And I love the city. I also love the country. And I think we take rural people for granted. They are resilient. They don't need to become resilient. They are resilient. And so I'm hearing a lot of that. I'm also hearing some really fantastic stories about what change has been able to occur with the right policy levers and with the right funding levers by government. Because in many of those regions, especially in any population between 3 and 12,000 people, 15,000 people, often market fails there. You don't have the mass of people, delivery is more expensive, and so they need to be supported by federal and state governments. They also need to be supported by industry and local government. And they want to work with stakeholders.
Absolutely. And, I was attending some sessions before hearing about communities of 37 people that, that the resilience piece is something that you won't see anywhere else in Australia. And the reliance on the individuals within those communities to just keep going is it does certainly demonstrate the resilience that we have in those areas, but also the healthcare needs in those areas too, like the toll on mental health, the toll on the workforce, and the opportunities for new ways of doing things that represent. And I guess, Aileen, you've probably seen that, given that you mentioned that been supporters of the Alliance for a couple of years now. Talk to me a little bit more about how the solutions that you're bringing to market here will really address some of those issues that are being raised in these regions.
Right, thank you. So I think the first thing in the principle of designing a product or a solution is it boils down fundamentally to the intention and the principles of it. So what I'm alluding to is, even as a vendor, for example, there's a lot of time it's a chicken and egg thing. Is, can I get revenue out of what I'm building in exchange for what I'm designing, a product or a solution? The fortunate and unfortunate thing, for example, in rural health, like what Susi has mentioned, is probably a lot difficult because technically there's less people. It's most costly to deliver the same solution, whether it's in the metro area. So from fundamentally how we do it from HealthBeats' perspective is we make a choice to invest first. We put in the right resource, we put in the investment. For example, we spend more than a year of R&D researching on making our platform offline enabled, because we know internet is so basic, and it's even owning a smartphone or having a stable data line is a challenge, a big fundamental challenge. So we spend a year researching everything we can to see how can we continue our client can continue to use the platform with or without internet, as basic as that. And so these are some of the things we try to address. We try to address the remote health, for example, a shortage of healthcare workers, and we've tried to look at how to make a lot of things, monitoring a lot more productive for them, and to make it as easy to use for them. So these are some of the smaller things that we do as a solution provider to help to support all these deployments.
Yeah, and you're operating primarily in that remote patient monitoring space, as I understand, and that is in Australia and in rural areas. That's a critical capability, because it means then that someone who might be in an area that doesn't have a specialist or someone that can just pop by, or they can't just go into the city and see a clinician, there's the ability to do those things remotely. Talk to me about that journey of bringing some of these solutions to market, because we know that the funding is required to be able to deliver care with different models of service, and we've seen different levels of excitement about that here in Australia. In terms of I guess the product market fit of some of these solutions? We see some great devices over there out here in the booth too that then tie in with software. Is that right? So talk to me about how it kind of fits into the Australian healthcare ecosystem and those problems.
All right. So what we have envisaged is actually to build the entire solution to see through patient as in their entire healthcare journey in terms of from chronic disease management to acute and back to chronic. So we are looking at a single patient record where the healthcare provider can provide better health. So this, as a digital health, it transpire distance, it transpire hopefully internet access, and it transpire a lot of other factors that that's of digital health. So as a platform, it's our IP. We actually connect to multiple brands of devices and whatever it takes to help our client be able to collect their vital signs data or consolidate it into our platform. On the other hand, our platform is heavily customized flexibility to support different health services in their work process, in caregiving, in their protocols and threshold management, for example, to help to deliver the level of care they need remotely. Yep.
Hey, Susie, there'd be a lot of, you mentioned, there's your members that you're supporting, but also working with a lot of different partners around and representing a large portion of the Australian population. There'd be a lot of initiatives kind of on the horizon for you and the priorities there. Talk me through what some of those are and I guess how that might tie in with people within the broader healthcare ecosystem in Australia.
I'd like to follow up on something that you were saying before about technology. Technology for us is an enabler. It is not instead of, or, it is in addition to. And so that includes telehealth, it includes, store and forward or asynchronous health. It is about being able to support that person in their journey to be able to get the best access to healthcare that they can, and that their primary care clinician has access to that information to best manage that particular care. And we're working with all of our groups in that, and we have been providing quite a bit of input into all the reforms and reviews that are currently going on with the Australian government. It is crucial that people do have access to technologies, and it is also crucial that they understand how to utilise it, because the health literacy and the health system literacy is still a bit of an issue in terms of uptake, but also integration with systems that currently exist. So in terms of our groups, we really, across research, across the patient journey, across delivery of health services, we're really focusing on making sure that we build the next workforce across the patient journey in rural communities. We know that if we train rural people, they're 7 times more likely to go back or stay, which is a significant amount of people. The second thing is we're also looking at different workforce models where we can have people working across different sectors, so aged care, disability, healthcare delivery, and that we have the legislative structure, because Australia is a federated, it's a federation, but it actually has different legislation in different states, and we shouldn't actually have any borders, but we do, and we try to deal with those. And so we try to make sure that whatever clinician you are, you're able to work to your full scope of practice, because that's what people are trained to do. And really the other piece is about working with communities, because communities often understand their health needs more than an urban centre deciding how things should be delivered, because no one community is the same. And it's not an arrogance or an ignorance by saying our community is different. It actually is because they really are different. They might not have all the workforce on the ground. They might not have the internet coverage, as you were mentioning before. They might not have the technologies, and they might not have the structures behind them to deliver the healthcare that they need. So let's look at it in a different way. Let's be flexible. Let's see how we can do that.
Amazing. Aileen, I would be interested too from your side, given that you've seen, the application of remote patient monitoring and different technologies in countries outside of Australia as well. And Australia is quite uniquely placed in terms of the the geographical size in terms of the population, and I can see how remote patient monitoring acts there. But it's always interesting to look in other parts of the world too, in terms of how they're tracking with some of these technologies. Are they ahead? Are they behind? Or where do we place in all of that? I'd love like a quick thought in terms of how the rest of the world is adopting some of these technologies and the impact it might have.
We have seen a lot of differences between Australia. Australia is pretty unique in a way. We have also worked with remote communities, for example, in countries like in Asia, in Indonesia, Philippines, where unfortunately government is not playing an extremely active role in reimbursement. The healthcare system in reimbursement is very, very different. I've seen in the US as well. In terms of, for example, Medicare is covering a lot of remote areas. They are straddling with the same set of problems in remote and rural health as well. So I would say that if you look at generally across board, everyone is struggling with rural, and rural is given. The struggle is given. But the specific, when we go down to the ground, just like what Susi mentioned, every community is different. Every country is different. When we go to a country, we go to a different state, is different again. The language, the culture, the religion, the style, and the practice. So in other words, what I'm alluding to is that compared to other countries, there are some things that Australia has done really well. One of the things is, for example, a lot of great work in terms of research. A lot of other countries are less structured, less resources attributed to research in doing what is right in a very structural manner. On the other hand, countries like in Asia, that have less government involvement, for example, they are not part of the reimbursement model. They are a lot more creative because they work with insurers, they work with employers, individual pay. A lot of creative ideas start to sprout up. So if you ask me for my personal opinion, I think Australia can gain some from the experience of others, whilst the experience of other countries can gain a lot from what Australia have done as well. But what I'm alluding to is that if there's cross-collaboration, I think there's a lot of value in it as well, in looking at different backgrounds.
Yeah. Hey, building on that idea of collaboration, and lastly, Susi, perhaps thinking about, so your opening presentation for the conference and calling on members to collaborate and open up to new innovative ideas of thinking, here at the event and onwards. But what are you hoping that people take away from attending the conference over these couple of days and apply back in their health setting?
Well, it's interesting. I've already spoken with a few people that have actually joined up with others and said, look, we're doing something similar. We would love to learn from you. How are you doing that evaluation? How have you involved industry? How have you worked with local government? We want to learn from you. And I think that's one of the things about a conference, is that people have the opportunity to do that. The industry collaboration and the innovation that you were talking about before is really important. Interestingly, we can learn a lot from industry. So the DVA in the US has been doing telehealth for many, many years, and 70% of those people are in rural, remote and regional Australia. But they're funded. And so, we should be able to adopt things from other countries and adapt them from others. And there's a great opportunity to do so. And let's have some flexibility, because that's what you need to be innovative.
We hope you enjoyed this episode of Talking Health Tech. Make sure you like and subscribe and share this episode with someone who might find it valuable. For more information and resources about healthcare innovation, visit talkinghealthtech.com.